Okay, so we're looking at endocrine, and this is the second lecture. When we look at the endocrine system, you should recall that they're glandular structures, which means they're made of epithelium, and these glands are multicellular, which means they're going to be a stratified cuboidal tissue type. They're highly vascular structures that produce hormone. You should know the definition of a hormone. Remember, there was a slight difference between transmitter and hormone. One acted locally in a synaptic cleft, and one was delivered into the circulatory system, and the circulatory system carried that substance wherever it was destination, was wherever the target was. And we're going to go through several different glands in this system. There will be a table in the end of the chapter that you'll want to refer to as well, of other organs and systems that do produce hormones to act locally or on your overall physiology. About hormone, there's three types of hormones. You have the steroid hormones, which are derived from cholesterol. You have amino acid type hormones, which are protein natured. And then you have that special class derived from fatty acids called eicosanoids or eicosanoids. Any hormone, once it's done its job, generally is going to be broken down by the liver and eliminated through the kidneys. So you should know, if you're asked, there's a liver question. One of the many functions to the liver is to catabolize hormone. Again, there's three types of hormones, two by your textbook's category, and then a special class called eicosanoids. And there's a little table in the Chapter 2 chemistry notes that you might refer back to that talks about eicosanoids and steroid hormones. And more importantly, you'd know what the Chapter 16 or endocrine chapter has to say about that. Remember, the master of all glands is the hypothalamus, control center of endocrine and autonomic function. In this picture, you can see a hypothalamus controlling or related to functioning with the pituitary. You see a named tract here. You remember a tract was a bundle of axons in the CNS, so this is technically CNS in nature then. On the other side, you have your more glandular portion, which is why we call this anterior pituitary the adeno hypophysis. Adeno meaning glandular. You can see, as far as pituitary output, you have 6 hormones being produced by the anterior pituitary. Technically, here you have no hormones being produced by the posterior. Those hormones come from the hypothalamus, are stored and released when necessary from the posterior pituitary. Posterior doesn't actually produce these hormones. Those are hypothalamic. Again, the control center for both endocrine and autonomic is the hypothalamus. There will be a sympathetic, parasympathetic overlap between the end of part 1 and the beginning of part 2. Remember, the hypothalamus was the master clock of the body, sets your circadian rhythms. It's the official timekeeper. The hypothalamus produces 2 hormones. One's known as oxytocin, the other is vasopressin. Remember, the hypothalamus is linked to the pituitary by this connecting stalk called the infundibulum. More about these 2 hormones here shortly. If we look at the first of the 2, antidiuretic hormone is also known as vasopressin. Arginine is an amino acid, so this is a protein-natured substance. Vasopressin, by its name, tells you that it's going to control the smooth muscle of blood vessels. By its other name, antidiuretic hormone tells you it's going to antidiurese, meaning diuretic meant to produce water, to produce urine from water. Antidiuretic would then be a hormone that would cause you to pass less urine. Okay. And that means the water is going to be reabsorbed by your circulatory system. So ADH is a water homeostasis hormone. It promotes the conservation of water. And again, it's also a vasoconstricting substance, which means it's going to act two ways on your blood pressure. One is to affect the volume of water in your blood. If you're pulling water from the urine, that means the urine is going to get darker or more concentrated as there's less urine. And if we send that water into the bloodstream, well, that's going to increase volume and thereby increase blood pressure. There is an endocrine condition related to ADH, and that is known as diabetes insipidus. Think of SIP, insipidus. It's water diabetes. Okay. There's two P's associated with it, polyuria and polydipsia. Poly meaning excessive thirst and excessive urination. Polyuria, polydipsia. There's two types. Central means it's brain related, meaning your hypothalamus pituitary axis. And the other term there, nephrogenic, means it's acting or it's a kidney related issue. So there are two reasons or two types of diabetes insipidus. Remember, insipidus is not sugar diabetes, and that's the more common that you've heard of before and that your patients will be thinking about. The second of the hypothalamic hormones is oxytocin. Oxytocin is known as the cuddle hormone. It's the hormone responsible for trust, bonding, and love between two individuals. Okay. Oxytocin is also referred to as the labor hormone. It's a positive feedback hormone acting on the smooth muscle of the uterus. And in women, it also affects the breast to release milk. So we say letdown versus production of milk. Production is going to be prolactin. The release of milk is going to be referred to as a letdown reflex, seen with nursing. And that was the posterior pituitary and hypothalamus interaction or relationship. If we look at the hypothalamus governing the function of the anterior pituitary, you can see a whole host of hypothalamic hormones, and I'm not going to beat you up with all these in name. If I picked one just for practice and principle, or two, it might be CRH and it might be TRH. And you can see the CRH stands for corticotropic releasing hormone, so it would affect the anterior pituitary to release corticotropic hormone. And the TRH is going to be thyroid releasing hormone affecting thyroid stimulating hormone. So it was once thought that the pituitary was the master gland of the body. It is the master of peripheral glands, but its master is the hypothalamus. And you should remember that the hypothalamus is part of the diencephalon. It's a glandular-like structure. It serves several functions, but as far as parts of your brain secreting hormone or chemical, remember the hypothalamus produces releasing hormones and the two that I just mentioned. And then on the other side over here, the picture doesn't illustrate it, but you would have an epithalamus which produces melatonin. So the diencephalon produces 3 hormones. And then 6 of those regulating factors. So onto the pituitary. When we're talking about the pituitary, we have 6 adenohypophyseal tropic hormones. Okay. Tropic tells you they're going to turn on the function of other peripheral glands. And this is the part of the pituitary that would be a little more vascular in nature, because when you produce hormones to control other peripheral organs, you want those hormones to immediately enter bloodstream. And those hormones are TSH, which is thyroid stimulating hormone, PRL, which is prolactin, CTH, which is corticotropin hormone, LH, which is luteinizing hormone, and FSH, which is follicle stimulating hormone. The last 2 act on the gonads. CTH acts on the outer adrenal gland. Growth hormone acts on skeletal muscle and joints, any tissue related to your skeleton and skeletal muscular system. Prolactin acts on the breast, and thyroid stimulating hormone by its name stimulates the thyroid. So I'm going to start out with those gonadotropic hormones. There's two of them. One is called LH for luteinizing hormone. It is produced by gonadotropic cells. Don't be confused by the word gonadotropic. Just because it has the word gonad in it doesn't mean they're found in the gonads. It says these are cells that control the gonads. Okay, if I jump ahead real quick to thyroid, you have a group of pituitary cells called thyrotropic. So it says there are cells that are going to control thyroid function. So keep those straight. One last example is corticotropic hormone affects adrenal cortex function. So again, these are not cells of those organs. It says these are cells that control those organs. So those three mentioned, thyrotropic, corticotropic, and gonadotropic, control the peripheral organs. So LH in females promotes ovulation. LH in males affects sex hormone, testosterone, and androgen production. So in the female, it's both sex hormone production and ovulation. Down at the very bottom, which I'll repeat again later in lab at the end of the semester, you should know that the testes, specifically the Leydig cells or interstitial cells of Leydig, produce male sex hormone, and male sex hormone affects male behavior and masculinization, meaning hairy body, deeper voice, thicker larynx or vocal cords, more skeletal muscle, larger skeleton. In the female, the ovaries, there's going to be a structure that develops monthly called the corpus luteum, which means yellow body. That's going to be the structure that an actual egg ovulates from, ruptures from. But the remaining cells that remain behind when the egg is released from the ovary are collectively called the corpus luteum, and they're going to produce female sex hormone, which would feminize a female. Better skin complexion, distribution of fat, protective effects on the heart, etc., which we'll talk more about later. Breast development. The other gonadotropic hormone is called follicle stimulating hormone. So again, these two substances come from the anterior pituitary or adenohypophysis. And FSH in both sexes affects the production of gametes, which is a fancier way of saying sex cells. And the two sex cells that we're talking about would be male spermatozoa and the female egg, known as an ovum singular or ova plural. And nature provides both sexes with an abundance. We know it takes one sperm and one egg. You'll learn more of the vast numbers of cells that are produced by both sexes. Gametes obviously come from the gonads, and specifically you would know testicles and ovaries. Prolactin, abbreviated PRL, is produced by pituitary cells called lactotropes. Lactotropic cells affect the production of milk at the breast. Okay. So prolactin promotes lactation, promotes the production of milk. Thyroid stimulating hormone tells the thyroid to produce thyroxine. So the hypothalamus, which is the apex of the axis of control, the hypothalamus tells the pituitary by way of TRH to produce, the pituitary then produces TSH. The pituitary releases that TSH into circulation, and it acts on the thyroid to produce T3 and T4, which is triiodothyronine and thyroxine, which you'll learn more about when we get to the thyroid. CTH or ACTH acts on the adrenal cortex. Pituitary cells in the that control adrenal gland function are called corticotropic hormones. They're going to control the cortex to produce steroid hormones, such as glucose regulating hormones and salt regulating hormones, which we'll call cortisol, and aldosterone. Lastly, for the pituitary regulating hormones, we have growth hormone. By its fancier name, it's called somatotropin, or anabolic steroid hormone. And you hear about anabolic steroids in the news all the time when males and females are trying to get an edge on their other competitive, beat their competition and other athletes by injecting themselves with anabolic steroids. Growth hormone is an anabolic steroid, and so are the androgens, male sex hormones. Down at the bottom, you can see the effects and the target. Target is most cells of the body, especially the skeleton and skeletal muscle. The effect of growth hormone is going to increase muscle mass. You know that if we're going to increase muscle mass, that means we got to lay down more protein in muscle cells or fibers. So you should think about your chemistry and your cytology when you were once taught about protein synthesis. You're not going to get beat up with protein synthesis here, but it would be nice if you could remember transcription, translation, and think about how those events take place. Growth hormone stimulates protein synthesis. So some endocrine conditions. In the first intro video to endocrine, I had mentioned that more than any quiz or test that you've had in part 1 and in this course, you're going to have diseases and disorders show up on your first test. And that would mean the big glands are what you would worry about most, and then you'd come back and maybe expect a question or two from different disorders from different systems. Gigantism and dwarfism are probably a low priority. All of you as health professionals should know everything that I and the book say about diabetes mellitus, which is the sugar diabetes. You should understand pancreatic disorders, that would be your diabetes. You should understand Graves' disease, which would be a thyroid-related disorder, and adrenals. So if you're going to focus on diseases of 3 major glands, you should focus on adrenal disorders, thyroid disorders, and pancreatic disorders. Not to say that the other diseases and disorders of other glands aren't important, but we got to draw the line somewhere. So you should expect a heavier emphasis of potential questions from those areas. So gigantism is caused by a hypersecretion of growth hormone from the pituitary. Often what goes along with gigantism is something called acromegaly, which means that you're going to have big bones. And dwarfism would be the opposite. Less than normal output of growth hormone. The result is a dwarf. If we move on to the first of our peripheral glands, we look at the adrenals, and that might be a review from part 1, depending on how far your part 1 instructor went. You should all have been taught that the adrenal glands were sympathetic. And sympathetics involve tiger wanting to eat you if it's an acute stress. And again, if you're becoming a healthcare professional, and you are if you're taking anatomy and physiology, health science or life science students are under a lot of stress because you got to make good grades to get the degree or diploma to work in a hospital someday. So you're going to know what chronic stress is, and I'm sure you already do. So about the adrenal glands, real quick anatomy is that you should know that the adrenals are sitting on top of the kidneys, therefore they're called suprarenal. Suprarenal. The adrenal gland is really 2 parts. There's an adrenal medulla on the inside and adrenal cortex on the outside. The adrenals are part of the sympathetic nervous system, which is outlined here. You can see the hypothalamus responds to stress. The lateral horn of the spinal cord sends its impulses to the adrenal medulla. The adrenal medulla responds by producing a class of neurotransmitter called catecholamines. You would work on understanding the short-term stress response. Catecholamines are known as epinephrine and norepinephrine. And that's acute stress or short-term stress. On the other side here, you can see that the outer portion of the adrenal gland, called the cortex, releases steroid hormones. There's actually three. She only illustrates two of them here. The two more important for this course are the mineralocorticoid class, the primary being aldosterone, salt-regulating hormone. And on the other side here, glucocorticoids, the primary there being cortisol. And a stress researcher and leading stress expert, Dr. Robert Sapolsky at Stanford University, is one who studies chronic stress, and glucocorticoids are his bag. You should check him out. He's an interesting author. If you haven't heard of him yet, you will throughout part 2. So about that adrenal gland, again, it's a sympathetic structure, which is why you see it listed here from a table back when you were a part 1 student. Adrenals are sympathetic. Again, the outside adrenal gland was the cortex, the inside is the medulla. The inside is involved with acute stress, short-term stress, and the cells that produce the catecholamines are called chromaffin cells. And you can see the book is going to say the same thing. There's about an 80-20 relationship between epinephrine and norepinephrine output. Norepinephrine is primarily released by neurons of the sympathetic nervous system, while epinephrine is primarily released by the endocrine gland, or the endocrine portion of the adrenal, known as the adrenal medulla. And you should know the effects of epinephrine and norepinephrine. Epinephrine is a heart stimulator and bronchial dilator. It's the primary substance of the fight or flight stress response. And epinephrine and norepinephrine, for that matter, are derived from amino acids such as tyrosine and phenylalanine. You should also remember that epinephrine acts on antinergic receptors. Again, antinergic receptors, alpha and beta, are found on the target organs that the sympathetics control and regulate. Epinephrine is involved with reversing anaphylactic shock or anaphylaxis, which is why you hear of some people carrying EpiPens when they have an allergic reaction, whether that's a bee sting or some allergy to some food they may have accidentally ingested, or maybe a severe asthmatic attack where their airway shuts down on them. The cousin substance that goes along with epinephrine is norepinephrine, which is also fight or flight stress response. There are a collection of neurons that I'm not going to expect you to memorize, but maybe a bonus someday, called the locus coeruleus, which means blue spot, and it's located in the pons of the brainstem. That's probably more just an FYI. Norepinephrine primary target is going to be the smooth muscle or blood vessels, causing vasoconstriction. So epinephrine increases heart rate and the force of contraction of your heart by acting on beta receptors. And when we're talking about smooth muscle, it would be alpha receptors, and it would involve your norepinephrine. So they work together on cardiovascular function. And epinephrine, again, also causes dilation of the bronchi. About the adrenal gland, it's the outside. It's divided into 3 zones. Your new book also talks about the hormones. I'll mention them along the way. So if we look at the outside of an adrenal gland, it's going to be surrounded in a capsule of connective tissue, and immediately below that is going to be the zona glomerulosa. The zona glomerulosa produces mineralocorticoids, which would be your salt-regulating hormones, and the primary one that you would know in part 2 endocrine would be aldosterone. I'll say a lot more about that throughout the semester. Aldosterone is a mineralocorticoid that comes from the zona glomerulosa. Next up, as we work our way deep into the adrenal gland, is the zona reticularis. The zona reticularis produces cortisol, or glucocorticoids, sugar-regulating hormones. You think about with chronic stress, you want to maintain sugar in your body. Glucocorticoids regulate blood sugar, or have an effect on sugar metabolism. So it's not just the pancreas and insulin glucagon, but this area of the adrenal gland. And lastly, we have the zona reticularis. That's going to be the part of the adrenal gland that produces gonatocorticoids, or sex hormones. So if you're male, you don't have ovaries. If you're female, you don't have testes, but you do still have estrogen in your body if you're a male, and if you're female, you still have some androgen in your body. Well, those hormones got to come from somewhere, and that would be this portion of this gland. Some say the liver as well, so that's an acceptable answer too. Liver and the zona reticularis of the adrenal cortex. Now these are steroid hormones, which means they're derived from cholesterol. Your mineralocorticoids, the primary mineralocorticoid that you would know is aldosterone, and the primary salt or electrolyte that it regulates, mineral that it regulates, is sodium. It affects both sodium and potassium, but you're going to know sodium first and foremost. So about the regulation of sodium, mineralocorticoid, especially aldosterone, you can see this complicated mechanism. If you're a visual learner, you probably should study that well. That'll help you. Over here, when you look at the written content, I get a little carried away with my color, so I'm sorry about that, but there it is. Aldosterone. Aldosterone regulates sodium, and wherever sodium goes, water wants to follow. And that means that we're going to take that salt that would normally have gone and been passed in urine, we're going to reabsorb the sodium. And when we reabsorb sodium in the kidneys, water follows. The word reabsorption is a term that you should know. Reabsorption means we're going to go from the urine back into the bloodstream. So the kidneys are constantly filtering your blood. And as a result of filtering your blood, they filter out some of the salt and water. Well, if you have a need for greater blood pressure, short-term stress, long-term stress, or maybe it's some other reason, including diseases and disorders, if you have elevated blood pressure, it could be because you're retaining salt or you're retaining water. We're not getting on, I'm getting a little off track here because I want to stick to the normal stuff first, but the purpose of aldosterone is to reabsorb sodium. And where sodium goes, water follows. So if water re-enters circulation, that means blood volume is going to go up. And if blood volume goes up, blood pressure always goes up with it. So that means urine volume goes down. And if your urine volume goes down, that means you're passing less urine. That urine is going to be more concentrated, meaning darker yellow. Aldosterone causes the reabsorption of sodium and the excretion of potassium. Aldosterone is actually regulated by renin, a substance that you may have remembered studying in part 1 because it was in the autonomic chapter. There's a relationship between your sympathetic nervous system telling the kidneys to produce renin, and your kidneys would then be involved with raising your blood pressure. So renin increases aldosterone essentially. And you can see there's a long mechanism, chain reaction there of different hormones engaging and then causing the release of other hormones. And I'll actually read this one slide to you. I generally don't read slides very often, but to explain it through. So you have cells in your kidney called juxtaglomerular cells, also sometimes known as granular cells. And in their granules of their cytoplasm, they store renin. And that renin is a hormone produced by the kidney cells. Well, renin acts on a substance that naturally occurs in your plasma, which is produced by your liver. It's a plasma protein, which means it's in your blood, but it was produced by your liver, and that substance is called angiotensinogen. And what would be an easy thing for you to do and start now is that whenever you see a word ending in -ogen or having the word pro in front, and this will also be included in the GI system, it means it's an inactive substance. So to say what's not on the screen, this would be an inactive plasma protein. When angiotensinogen passes through or encounters renin, renin cleaves off part of the name as you notice on the screen, and angiotensinogen becomes angiotensin 1. Okay, so now we got 1. When 1 encounters ACE, which is produced by your lungs, now angiotensin 1 becomes angiotensin 2. And if you look at angiotensin 1, what's happening? It's being converted into angiotensin 2. Well, that's what ACE means then, angiotensin converting enzyme. produced by lung cells. So we would call those pneumocytes. Okay, lung cells produce ACE. And then lastly, there at the bottom of that flow, you can see that angiotensin 2 triggers the release of two hormones. If you look at the blue there first, it triggers the release of ADH. It's not that long into this lecture. Where did ADH come from? Your hypothalamus. It's also known as vasopressin. And that directly affects water. I don't think I said that earlier. ADH directly affects water volume. Aldosterone directly affects sodium and indirectly affects water. So both of these together, they work together. They're synergists. They work together. You're going to learn about another hormone later, which I'll bring up now just for the point of comparison. It's going to be called ANP, which stands for atrial natriuretic peptide, which is produced by your heart. And it's antagonist to this whole renin-angiotensin mechanism. So the very bottom there, you see that we're increasing blood volume both by ADH directly and by aldosterone indirectly because we're affecting sodium. A lot to say about that. It's going to keep coming back throughout part 2. Next up, we got the glucocorticoids, which are the sugar regulating hormones, and that major sugar hormone that you should know is cortisol. Cortisol is produced in response to chronic stress. So there's a C in cortex, there's a C in cortisol, and there's a C in chronic, if that helps you memorize that. Now, what stimulated the release of cortisol? It was CTH from your pituitary, and CRH told your pituitary to produce CTH. CRH comes from your hypothalamus. Back again to that point I made at the beginning that you have an axis of control with the hypothalamus governing all, the pituitary governing peripheral organs, of which the adrenal glands are a peripheral organ. Now, cortisol is involved with elevating blood sugar. That blood sugar comes from catabolizing protein and breaking down or catabolizing fat. Okay? And the protein pathway in biochemistry is probably the most complicated of all three of the macromolecules that you consume. There's actually 4 if we include the nucleic acids, but you can see in the middle of the screen there the word gluconeogenesis. That means to form new sugar from non-sugar sources, such as protein and fat. The organ of metabolic conversion is your liver. There is another liver function. You should start a liver list. You should already know some liver function from part 1 as well. So take a minute to think about that. So I've said 2 different things about the liver in this 30-minute lecture. One was that it produced, or it's involved in the conversion of protein and fat into sugar, or into energy, we'll say, and eventually into ATP. And angiotensinogen, which was that inactive plasma protein that I just mentioned a moment ago. Cortisol peaks in the morning, okay. Lowest when you go to bed. Flip to that, melatonin is highest at night and burns off, okay, in the morning. Melatonin makes you sleepy. Cortisol wakes you up. Stress, we're talking about stress. There's the medical dictionary definition of stress. You should know that. You should know that most hospital visits are stress related. Stress doesn't actually cause disease, but it pushes you over the edge. If you're already stressed, and if you have a disease and you're stressed, stress increases disease. It increases one's risk for cancer. It causes a whole host of problems. So important to manage your stress through breathing, through exercise, through sleep and diet. Said that we had some gonadocorticoids, so I just threw them up on the screen for you to glance at. You got male sex hormone and female sex hormones that come from this gland. Again, specifically the zona reticularis. You can look back at that picture for yourself. Some conditions related to your adrenal gland, and we'll wrap up this lecture and have a third. Hyperadrenalism is known as Cushing's. Cushing's disease is high cortisol. When cortisol is high, you get a list of different signs and symptoms. Picture of hyperadrenalism or Cushing's. This is the same woman in both pictures. Endocrinologists generally aren't real kind with their descriptions of things. This woman here, you can see in the normal picture and the disorder picture, has a buffalo hump, this pad of fat on the back of her neck. You can see there's a change in her integument. Hair looks a little different, skin looks a little different. Often you'll see a reddish face. In this case, you can see she's got some swelling in her face. Well, endocrinologists call that moon face. Having edema in her face is called moon face. If you could see her trunk, you'd see that, and endocrinologists refer to that as truncal or central obesity. She'd have thin extremities, but bigger torso. And then if you saw the torso as well, you can Google it yourself. You see purple stretch marks, or striae as they call them, across the skin. Last point worth mentioning is that they would also bruise easily. Ecchymosis is a fancy term for bruising, and they'd have poor healing as a result of the circulatory issues. Another picture here to show you real quick, if I can get this to work. Let's see. There you go. There's a picture from the internet. Okay. You can see the moon face in this gentleman here, central obesity, the purple striae. So, there we go. Other side of adrenal disorders, hypoadrenalism is Addison's. And with Addison's, the most legendary, famous figure would be President Kennedy. So we're looking at low cortisol. Often people thought Kennedy was healthy. He was taking steroid injections to help him with his particular disease and condition. And the bronze skin or glow that he seemed to always have, there's a picture of him, was related to his Addison's condition. So sick, weak, poor circulation, bronze skin appearance. He was dependent on steroids. As you looked that over. And the last slide about adrenals, and they'll wrap up. You can read there that there can be adrenal tumors that are male and female, causing women maybe to have excessive hairiness or masculinization, versus on the other side, feminizing tumors in males might be the result, or causing gynecomastia, which is developing breast tissue. Males developing breast tissue. That's also common, by the way, when males get a little too heavy and obese, that they also get a little gynecomastia with that too. So that's not exclusive to adrenal disorders. That wraps up endocrine 2. Actually, second that, I'm going to wrap up with one last hormone, seeing as I already brought it up. The antagonist to the renin-angiotensin mechanism. Remember, renin controlled that cascade, which I'll bring back up so you can think about it in comparison. Again, renin, produced by your kidneys, acts on angiotensinogen, which was produced by your liver and found in plasma. Renin converts angiotensinogen into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 by a substance produced by your lungs called angiotensin converting enzyme. The end result is angiotensin 2 stimulates thirst, stimulates the secretion of aldosterone and ADH, which both have an effect at elevating blood pressure by elevating blood volume. Well, the antagonist is a substance produced by your heart called atrial natriuretic peptide, which says that it's going to produce salty urine. So we're going to reduce blood pressure by reducing the water in blood, thereby lowering blood volume. And if we're pulling that water out of the circulatory system, then we're pushing it through the dam or the reservoir, and the kidneys are allowing that to move on to your bladder. And you remember diuresis, micturition were parasympathetic in nature as far as functions go. So that will wrap up